Psoriasis is one of the common conditions that we usually see in dermatology, and today we shall look at the current updates of this condition in regards to its etiology, pathogenesis, clinical presentation, as well as updates on its treatment. I'm Dr. Abraham from A&E Dermatology Specialist. So psoriasis has been with us for a couple of years, and we look at it as one of the chronic immune-mediated polygenic condition, whereby some individuals are predisposed to developing this disorder. And at the same time, we think that environment has a role to play with environmental factors, including trauma, infection, medication, in genetically predisposed individuals being the triggers for development of this disease. So clinically, we know psoriasis to present as a well-demarcated erythematous plaque with an acacious scale. Sometimes we call it a silvery scale, and this is the common presentation or the typical form of lesions we see in psoriasis. And in its histology, we usually see hyperkeratosis, parakeratosis, and we see acanthosis with a bunch of inflammatory infiltrate. Globally, we know that psoriasis affects about 2% of the global population, and we know that most of these people can also get systemic involvement where they get psoriatic arthritis, and this is about 20 to 30% of patients with psoriasis. They end up having joint involvement or what we call psoriatic arthritis. So when we are to look at history, where we started to see psoriasis appearing in history, when we go back in the days of Hippocrates, in about 300 to 460 before Christ, he was the first person to describe this skin disorder, and he grouped it together with other papillosquamous disorders, and he called them lopoi. And we think that wording possibly included psoriasis. So this is how Hippocrates looks like. That is his statute. And then later on, in 129 to around 99 before Christ, the term psora was described by Galen, and because of this scaling, we associate that description that usually gave of a lesion with a well-demarcated scaliness, which were thought likely to be eczema. We think this time round it is now psoriasis. So later on, it was distinguished from leprosy in around the 19th century by Robert Whelan in the 1809, and he was the first one actually to give a correct description of psoriasis. And then Hebra came in later on in the 1841 to officially separate the two entities. Remember, in this time round, they were looking at leprosy was the more common condition, so they thought that even psoriasis actually was part of leprosy. So Hebra is the one who actually described psoriasis as a separate entity. Then later on, we get Kobner, Heinrich, who came in the 1879 to describe the formation of psoriatic plaques along sites of injury, and that's what we call Kobnerization. So it is this Dr. Kobner that described this phenomenon in various skin conditions, and up to date, we actually call that Kobnerization every time you have a skin lesion appearing on the site of injury, on the site of trauma. So in this picture, this is how Hebra looks like. This is Robert William, and then this is Glen. We say that Hippocrates was the first one to call it lopoi. Then Glen came in later to call it psora, and we grouped them together with the eczema. And then Robert William came in to give the first accurate description of psoriasis. And then Hebra came in to separate the two entities. And then later on, Kobner was able to describe the appearance of psoriatic lesions on areas of injury. So when you look at its burden globally, it affects about 2% of the general population, and you find that in different countries or in different regions, the prevalence may be a little bit slightly higher. For example, in the United States of America, the prevalence is as high as 4.6%, in Canada, 4.7%. But when you come to the African belt, the African countries, the African Americans and the Asians, the prevalence is a bit lower, ranging between 0.4 to 0.7%. And when we look at its age of onset, psoriasis is one of the conditions that has a bimodal peak. bimodal peaks, meaning that it has two. If you have this as your graph, you'll find that psoriasis, if this is, it will occur at a particular age, and then shown to disappear, then later on it occurs again. So these two peaks are usually the first one usually occurs in the ages of between 20 to 30 years. Then later on it comes back again to occur at about 50 to 60 years. So that's what we call bimodal peaks. So it means that the psoriasis is common in two different separate age groups. So what we know that most of it, 75% of the cases usually occur before the age of 40 years. But even in elderly, we've seen patients as old as 90 getting initial attacks of psoriasis. So of these patients with psoriasis, we see that about 5 to 30% of them usually end up also developing bone involvement, joint involvement, what we call psoriatic arthritis. And the prevalence of psoriasis when it comes to the juvenile, the young patients, is about 0.07% in most parts of Europe. And commonly, they usually get the plaque psoriasis. So we also did a study at our clinic, I think last year. A study was done at Timber Regional Referral, a skin clinic, which showed a prevalence of about 2% of the patients that we see there. And this is a consistent with the global population. So as you look at this map, it tries to show you the distribution. We see the percentages 0.3, 0.7, 2.5. So when you calculate this, the average comes up to about 2% globally. So when you look at the overview of how this condition comes about, in the history or in the literature, you will find that different errors described, or at first they first thought it to be mediated by different mechanisms. The first one being initially, it was thought to be a keratinocyte disorder, and it is because of maybe over proliferation of keratinocytes that someone ended up developing psoriasis. However, in this theory, they were not able to show which mediators are driving the process or which triggers are there, but they thought it is a keratinocyte disorder. Though now later on there was a major shift in the thinking after the discovery of the T-cell involvement through giving agents that are usually cause immunosuppression, like cyclosporine. So you give cyclosporine as a trial medicine, then you see that it works well in psoriasis. Then you try to investigate backwards. So that's what happened. So when they started giving cyclosporine in the management of psoriasis, they discovered that it could work very well. And we know cyclosporine is an immune modulator, which specifically affects the T cell proliferation and function. So currently, the current understanding that we have is that psoriasis is a T-cell mediated immune condition, and it is driven by T helper 1 and T17 as the major pathways that drive this disease. So it is immune mediated, and we have not yet identified any autoantigen that has involved in the process, but however, we know that the T cells are at the core of the condition. So when you look at the roles that are played by the different cells that drive psoriasis, we start with the T cells. Now, when you look at the CD8 cells, these cells are usually in the epidermis, and as well as the CD4 cells also in the dermis are implicated in this process. And we have other cells like the dendritic cells, which are resident cells that are supposed to act as antigen processing and presenting cells. Also, thought to activate the T cells that come again later on to be involved in the process to give rise to the plaques that, as you're going to see later on. And we also have what you call cytokines and chemokines, or these are mediators that drive the process. We realize that the T helper 1 will basically produce the interferon alpha, and then the T helper 17 will produce the interleukin 17 and then interleukin 22. So all these are very critical in the pathways that are involved in psoriasis. Then other interleukins like interleukin 12, interleukin 23, tumor necrosis factor, and interferon alpha also kick cytokines that drive this process. Then the other thing that you usually also see in psoriasis is that sometimes they tend to get increased neutrophil infiltrate, especially in the acute forms, and also in the pustular forms of psoriasis. And these are also thought to be part of the drivers of the condition. So if you are to look at other cells, you also have the keratinocytes. Now, these are the cells that form the epidermis, and because of their hyperproliferation, they also take part in the formation of the plexus, and you are going to see how. So we know that also keratinocytes are very key in the innate immune system of the skin, where they're involved in producing the antimicrobial peptides like the defensins. Those are also very key in development of the plaques in psoriasis, and they also express different cytokines, including interleukin 1, interleukin 16, tumor necrosis factor, and all these contribute to inflammation and recruitment of immune cells. So we also have them sometimes overexpressing the STAT3, which is also linked to immune activation, and also this goes back to the pathogenesis in psoriasis. We also have a component of angiogenesis, because as we see in psoriasis, as we shall see later on, that we have increased vasculature in the plex, with the vasodilatation, angiogenesis, and this is mediated by the VEC, which is the vascular endothelial growth factor. Then we have keratinocyte proliferation that also contributes to the formation of these plaques. So how does this happen? So we know that we don't know actually how the process starts, but we have theories. So, and the first theory is that someone will get either a trigger which either comes from the environment or from within. So that is either from within or from without, meaning that you can have a trigger which is from outside the body, like things like injury, because we've seen psoriasis developing in areas of injury, or you can have a component in your body that triggers that causes the initiation of this process. For example, you can have maybe hormones like estrogen, progesterone, or you can have infections, or you can have cellular stress. That all of this resulting into initiation of the process. So now, whatever the trigger is, this is where we are, whatever the trigger is. So the trigger will cause stressing, or will cause stress or damage to the keratinocytes. So now, sometimes there's a thinking that either the damage initially is to keratinocytes, or you have antigens that are either from infections like RNA from viruses, or even DNA, or from stressed cells. So now this ends up to be taken up by the resident dendrocytic cells. So these are the cells that I told you that are supposed to process and then present antigens to the different immune cells. So when now this stress comes, it ends up bringing an antigen of any form, which can either be DNA, RNA, or any proteins or amino acid, that ends up being taken up by the dendritic cells. So now when the dendritic cells take up this antigen, they will process it and then migrate to go and express or take this information to the nearby lymphatic tissue, which is just below the skin there. So now when this dendritic cells, which is now having the antigen, moves, we say it's now activated, so that's why it is changing shape here. So to now go to the nearby lymphatic vessel, then when it reaches there, it will activate a particular line of naive T cells in the lymph nodes. So now these naive T cells, when they're activated, they'll undergo coronal differentiation, where they'll form for you specific T helper 1 cells, and then T helper 17 and T helper 22. So now when you have now activated these T cells, now these T cells will now undergo diapedesis. They will move from the lymphatic vessels, they will go into blood, and then they'll do homing. From blood, they will home back into the skin. So when they reach into the skin, remember now they are activated and they are particular. They are in response to a particular antigen or a particular chemical or a particular trigger that is located within the skin. So when they do homing into the skin, they'll now, since they're now activated, they'll now produce other immune mediators, other cytokines like tumor necrosis factor, interferon alpha, and then also interleukin 17, interleukin 22. Then we also so when you produce all those pro-inflammatory cytokines, the response will be is that they will now stimulate production of more keratinocytes, and then, the response is excessive production of keratinocytes that will now undergo more proliferation. When they're now activated, they'll now produce more cytokines. Also keratinocytes produce cytokines, as we mentioned earlier. So now all these cytokines, they will now start what we call a cascade. So now at first you had a trigger, a non-trigger activating these dendritic cells. Then the dendritic cells going to lymph nodes, activating T cells coming back to skin, activating more keratinocytes. Now more keratinocytes being activated, they'll produce more beta defensins, they'll produce more cytokines, they'll produce more chemokines, they'll produce more inflammatory mediators. So now the cycle will continue, because now the inflammatory cytokines from keratinocytes will now go again and stimulate more T cells, more T helper 1, more dendritic cells, and then the cycle continues. So it enters what we call a vicious cycle, where more activation causes more stimulation, more activation. So that's why you end up with hyperkeratotic plaques in psoriasis because of this process. So to summarize this, because the schematic may be a little bit more complex, so to summarize this, you have an environmental trigger as the first step. So now this environmental trigger will either cause damage to the keratinocytes or be any antigen that will be presented by the dendritic cells in the skin. So when you now activate or you damage these keratinocytes, now this will result into activation of the dendritic cells that will now migrate to the lymphocyte, to the lymph vessels, and then cause activation of the T cells. So now, because of this damage, you will have now production of pro-inflammatory cytokines, that is interleukin 23, interleukin 12, interleukin 17, tumor necrosis factor, interleukin 22, and the rest. So now this will result into activation of the T cells, which we say the T helper 1, 17, and 22. So the activation of this, now they will come back and then produce more cytokines. So of the cytokines, the major one being interleukin 22 will cause now the epidermal acanthosis and then abdominal keratinocyte proliferation, whereas interleukin 17 will give you the increased production of the beta defensins and then also the CXC chemokines, and all these will now cause more recruitment of more T cells and more neutrophils and more pro-inflammatory cells to be recruited in the area, and then the vicious cycle will continue. So realize that upon a trigger, this cycle can be very, very continuous, very vicious, So it will continue and continue and continue until when you come to rescue as a doctor. So the triggering factors in psoriasis have been a multitude and have been either categorized depending on the literature that you're reading. But I love categorizing them like this, where we look at the Koebner phenomenon. In this case, we've seen sciatic lesions developing along lines of skin injury. So meaning that one of the triggers in psoriasis is trauma, which can either be the physical trauma or even sunburn. And then in this case, it can affect up to 23% of patients with psoriasis, and sometimes they can be Koebner negative initially, but over time they can tend to be Koebner positive, meaning that initially someone can have psoriasis where there is no Koebner phenomenon or formation of lesions along lines of skin injury, but as the disease progresses, now they end up forming these getting this process of Koebnerization. So as we continue, so if you are to look at the systemic triggers, we can have things like infections, like some bacterial infections. We know that some infections like streptococcal infection, like pharyngitis, can provoke or even worsen psoriasis, especially the gouty type of psoriasis that we see in children. They can start with a sore throat, then they end up with worsening of their symptoms. Then other infections like HIV can aggravate psoriasis, and other endocrine factors like hypocalcemia. It has been linked to pustular psoriasis, and pregnancy can either improve or worsen psoriasis. You know, pregnancy is the funniest state when it comes to psoriasis. Sometimes some patients get even better when they get pregnant, others get worse. So other psychological things like stress has been shown to worsen psoriasis, and this is because of the cortisol response that we think triggers the disease response. Then drugs that people can be taking, like lithium, drugs like uh, beta blockers, antimalarials, corticosteroids, antihypertensives can also induce psoriasis. Then other lifestyle activities like smoking, alcohol, obesity have also been associated with psoriasis. So sometimes these factors or triggers may be a little bit hard for you to remember. So that's why I put here some mnemonics for you to remember. At least you can remember something like kiss me, where K stands for copner, that is injury, I infection, S stress, the second S is steroid withdrawal, then M stands for medication, and then E stands for environmental factors like weather, allergies, and even diet, and that's where you can put your smoking and the rest. Then you can also use the skin stress. I prefer skin stress because at least it gives more answers, where the first S stands for skin injury, which is the copner phenomenon, and then K stands for infections, that is strep and HIV. Then I, immune compromised patients, that's still HIV and more infections. Then a nutrition imbalance, that's where you have your hypocalcemia. And then another stress goes for stress, where you have the psychogenic stress. And then you have T standing for therapies. Those are the medications that have been shown to trigger psoriasis. And then R stands for rapid cortical withdrawal, as we shall see later on. Then E, endocrine changes like pregnancy, and S stands for smoking. Yes, and the other S stands for substance abuse, where you have alcohol. So in the mix here, you can also add obesity. So when you go to the clinical features of psoriasis, so psoriasis has been shown to present in various shapes depending on the person. But the common type, we call it the psoriasis vulgaris, and that's also called the chronic plaque psoriasis. It's the most common variant, and it presents with sharply demarcated erythematous scaly plaques. And the common sites, it loves the extensors. Those are the elbows, the knees, and also loves the sacral area. So when you see someone having those particular scaly plaques in those regions, you have to think about psoriasis. So you can have other forms like the gutted psoriasis, which will give you small, widely scattered papules. You can have erythrodermic psoriasis, whereby almost over 90% of the body is covered. You can also get psoriasis presenting as a fascicular type. We shall see some photos. And then in this case, the hallmark or the features that we usually look for is the erythema, thickening of the skin, and then the scaling. And then we have signs that usually elicit in psoriasis, including the Auspitz sign. So in this case, if this is your scaly plaque and then you remove it, you'll see areas of pinpoint bleeding. So those areas of pinpoint bleeding, that's what we call the Auspitz sign. So if it is positive, then definitely you may be dealing with psoriasis. Then there's what we call the Wolnoff's ring, and this is usually the pale blanching that occurs around lesions of psoriasis after you have initiated treatment. So this is usually seen after you've started treatment. This one is seen before, and you elicit it by removing the scale on the plaque that you see in psoriasis. So sometimes psoriasis can be a little bit itchy, or sometimes not itchy. Sometimes patients can tell you it's a little bit painful, and you can see some tenderness, and the lesions can vary in size, starting from very tiny papules, scaly papules, and all the way to plaques, all the way to erythroderma. Sometimes they are circular, other times they can be even polycyclic. So we can also elicit for copner phenomenon. This one, we've talked about it earlier, where you see lesions along sides of injury. So if someone has an injury along this line, then you see them forming lesions along that side, that side of that scar or that line of injury or scratch. So in chronic plaque psoriasis, we've seen this sharply defined erythematous scaly plaques, as you can see here. So all this is a well-demarcated scaly plaque having this silvery scale. It's also called a micaceous scale. So this is how it will look like. This is how it will look like. And we've also highlighted the common sites, the common site being the scalp, can be on the elbow, the knees, and in the lumbosacral area. Sometimes it also lasts the genitalia and also the feet and hand. So the duration is usually varied. This is a chronic condition. It can persist for months to years in the same location with periods of remission. Then after that, someone gets them the condition back on and off. Maybe after even 5 years, it comes back. So it is something that can sit with you for the rest of your life. And when you're assessing, there's a special score that we use, the psoriasis area and severity index, though this one is commonly used in research, but not in the routine management. In routine management, we tend to base on the body surface area that is covered, and then involvement of the areas like the nails, the oral cavity, the scalp, depending on the area of involvement. That one can also guide treatment. So we'll go to the second type. We call it the gutted psoriasis. Now, in gutted psoriasis, very common in children and young adults, often is secondary to respiratory tract infection, where we say that we have the streptococcal pharyngitis being one of the commonest bacterial infections that trigger this type of psoriasis. So in most cases, when you treat the bacterial infection, sometimes even the child can heal. And this is one of the hardest, actually the easiest type of psoriasis to treat, because when you have a phototherapy, they usually respond very well, provided you have also treated the underlying bacterial infection. So someone present with numerous small red drop-like papules on the skin, commonly on the trunk and limbs. And we've said that in most of the cases, children have a staphylococcal infection. So when you do the anti-streptolysin or even other markers of streptococcal infection, they can be elevated. So sometimes it resolves by itself, or other times it can proceed to progress and give you the chronic plaque psoriasis. So in this case, you see very tiny acute onset. Sometimes it comes and covers the entire trunk and limbs in a very short period of time with very tiny scaly papules. Sometimes it can also be pustules, so some little tiny pustules. So that is what we call the gutted psoriasis. So we go to the next type. The next type, we call it erythrodermic psoriasis. And you say that in erythroderma, we say that someone has erythroderma if any disease condition actually covers more than 90% of the body surface area. That is erythroderma. So in this case, one of the conditions that can give you erythroderma is psoriasis. So the patient will present with widespread redness and scaling across the body, and it can develop gradually or even suddenly at once. You can sometimes have a history of maybe treatment for psoriasis, default of medication, or sometimes it can be the initial manifestation. So when you're diagnosing and then you want to know that maybe this erythroderma is secondary to psoriasis, we have some diagnostic tools that you can base on. So if someone has a history of a classic psoriatic plaque in any area, be it the scalp, the elbow, the knees, you can go ahead and think that maybe this erythroderma is stemming from psoriasis. Then, if someone has psoriatic nail changes, which can include pitting, discoloration, subungual hyperkeratosis, and the rest, you will also think about psoriasis as one of the trigger. Then if someone has central facial sparing, it's more often in psoriasis. Usually psoriasis spares the nose. That one you have to remember. Psoriasis usually spares this area of the nose. So if someone has central face sparing, you can think about psoriasis being the trigger. Because we know the other trigger of erythroderma is atopic dermatitis. Other things like seborrheic dermatitis, other things like drug reactions can also give you erythroderma. So if a patient is erythrodermic, you may need to work around the history, the type of onset, the duration, and the rest, and you end up taking off a biopsy to make sure that you know the exact trigger of that erythroderma. Then in severe cases, sometimes it can be very unstable and it requires immediate attention and medication, even sometimes admission of the patient. And maybe for patients who have been having maybe chronic plaque psoriasis, if they may think that they are now cured and they stop the medicine suddenly, especially if they were on systemic steroid and methotrexate, they can end up getting erythrodermic psoriasis as a complication of acute stoppage of these medications. So we also have what we call pustular variants of psoriasis. And now in this case, we are looking at a presentation of psoriasis that gives you pustules, pus-containing lesions. So these are also classified further depending on the body involvement, with the first one being the generalized pustular psoriasis. So in this case, someone has a generalized pustules, thyroid pustules, with a bright erythema surrounding the pustules, and it has been seen in pregnancy, rapid corticosteroid withdrawal, infections, hypokalemia, and sometimes even irritants can also give you the same. So when it occurs in pregnancy, that's what we call the impetigo herpetiformis. And this is the generalized pustular psoriasis that is commonly seen in pregnancy. That is what we call impetigo herpetiformis. Then we also have other distinctive patterns like the von Zumbusch type. In this case, someone will develop sudden onset of painful erythema and pustulation, accompanied with fever, with some systemic illness like general body weakness, malaise, and it will resolve with scaling. And then in the other type, we get what we call the annular type, where you have ring-like lesions with pustules at the edge, and it heals usually centrally. So as the lesion spreads outwards, the central area clears up, then you have pustules surrounding the lesions. Then even the pustular type of psoriasis can be exanthematic, whereby someone gets very small pustules that cover the entire body all at once. But in this case, they will get quick resolution, and often times this type of pustular psoriasis is induced by infections and drugs like lithium. We can also have it localized, just like in AJEP. You have localized pustules, and then in this case, it is oftentimes due to irritants. So what you have to understand here is that disease conditions in dermatology tend to have variants that may end up looking like actually other conditions. That is why it is very key to have this broad knowledge that when I have psoriasis, how else can it present like? So in this case, if it is pustular variant of psoriasis, which other condition can it mimic? We've seen that generalized pustular psoriasis can look like AJEP, the acute generalized exanthematous pustulosis. It can look like the subcorneal the subcorneal pustulosis, or the Sneddon-Wilson disease. So we have to know which other conditions can present like that. Even DRES, they can also present with pustules sometimes. So associated disorders in this case may resemble other inherited autoinflammatory diseases like DIRA and then DITRA. So you have also to remember all these other conditions. So if I look at this picture, you will see that, if I may magnify for you, you will see that in this area here, we have a lot of pustules with the background erythema, which are generalized. Also in this case, we have what we call generalized pustular psoriasis. Then if you are to go to this other picture here, in this case, you have what you call the annular type of pustular psoriasis. So you have this plaque here that is trying to clear at the center. Then you have pustules being located at the margin of the lesions on a background of erythema. Then you have similar lesions like here, like there. So this is what we call the annular type of pustular psoriasis. So sometimes you can also get what we call pustulosis of palms and soles. So in this case, it is different from the acrodermatitis of Halupo, continuum of Halupi. So in this case, someone gets sterile pustules on the palms and plantar surfaces. So in this case, they will be mixed with yellow-brown macules, or even like hemorrhagic or purpuric macules, or even papules. And at the end of it all, they'll have also scaly erythematous plaques. And in this condition, sometimes it can be very, very chronic, staying with you for a very long time, and can be misdiagnosed as dyshidrotic eczema, or even tinea manum, or even the Pemphilox. So when you're looking at pustular eruptions, maybe if this is a child, you can even think about the acropustulosis of infancy. But in this case, it has to be only restricted to the palms and soles. But in some cases, when you get these pustulosis of palms and soles, if it is psoriasis, you may find that the person has other skin manifestations, maybe a plaque somewhere, nail changes somewhere, changes on the tongue. So you have to examine the patient wholly so that you know what else is existing in the same patient. So the pustulosis of palms and soles has been shown to be triggered by focal infection, stress, even smoking being one of the things that can aggravate it. It has also been linked to other conditions like the SAPO, which is synovitis, acne, pustulosis, and hyperostosis, and then osteitis. So it has also oftentimes been associated with the style inflammatory bone lesions. So sometimes it can occur together with chronic plaque psoriasis elsewhere on the body, or it can occur alone, or it can occur with even nail psoriasis or even oral involvement. So when you get pustules on the palms and soles, think about psoriasis as one of the possible differentials. Then we also have the acrodermatitis continua of Halupo. So in this case, you have psoriasis affecting the distal portions of the fingers, sometimes even the toes. In this case, you'll have pustules oftentimes followed by scaling, crusting formation. It can affect the nail bed, and then you see as if someone has passed below the nail, and can come with a nail dystrophy and destruction of the nail. And it can be uh, uh, like a form of transition to other forms of psoriasis. So someone starts with the acrodermatitis continua of Halupo, then ends up with generalized chronic psoriasis. So sometimes it can be accompanied with oral involvement, where you get the annulus migrans, which looks like a geographical tongue. So you end up having those two. So you have, every time you see this picture, you have to think about psoriasis, but as well as the other fungal infection of the nails or even eczemas, they can also give you that. Then we go to another type of psoriasis. We call it the scalp psoriasis. So scalp psoriasis is also one of the common type of psoriasis that can affect the hair and, the scalp. And in this case, you'll get discrete lesions. Sometimes they can confluent to give you a generalized plaque that covers the scalp, following along the hairlines, and it will be well defined. And it sometimes may be very hard to distinguish from seborrheic dermatitis if it is diffuse, and maybe it is not that scaly, but oftentimes it is very easy to tell a difference. And you can even have an overlap where what we call the sebopsoriasis. So there are two things here. So you can have scalp psoriasis. So in scalp psoriasis, you have well-demarcated scaly plaques, like the similar to those that you see on the body elsewhere, but now this time round, they're on the scalp. Then the sebopsoriasis, you have an ill-defined scaly plaque that covers almost the entire hair, almost following all the having a seborrheic distribution. So that's what we call sebopsoriasis. Then we have this term which I call psoriasis amiantensia. So in this case, you have a very thick asbestos-like scales that usually clamp along the hair follicle. So if this is your, let me see here, if I may draw, if this is your hair coming out of the hair follicle, maybe down here, then you have a very thick scale that is attached to this hair, a scale. That is what we call psoriasis amiantensia. And there are commonly two things that can give you psoriasis amiantensia, psoriasis being one of them. Then the other one can also be seen in seborrheic dermatitis. So that's what we call psoriasis amiantensia. Then as the potential complications that come with scalp psoriasis include things like infection in the area, especially if you are treating the patient with tumor necrosis factor inhibitors, and they can end up with hair loss, and sometimes they can end up even with the scarring. And what you have to remember is that you have to tell a difference between scalp psoriasis with other things that can look like it, especially on the scalp. And one of them we've mentioned is seborrheic dermatitis. Then the other is dermatomyositis. Dermatomyositis affecting the scalp can look like scalp psoriasis. Okay, then we go to another variant we call the fractional psoriasis. So in this case, you can also call it the inverse psoriasis. This one type of psoriasis will affect the intertriginous area, including the axilla, including the genitalia, inframammary area, the neck area. So all the folds can be affected. So in this case, you have to be very careful because in these areas you have sweating, a lot of sweating, and the sweat has maceration effect, meaning that it will take away the typical scale that we usually see on the rest of the body. So in this case, you'll have a well-demarcated erythematous plaque, but may lack the typical scale that we usually see with the rest of the body. So this should be very key when you are looking at interdict fracture involvement of any condition, because inverse psoriasis, inverse lichen planus, inverse seborrheic dermatitis, inverse atopic dermatitis, even the simple intertrigo, they can look actually the same. Even intertrigo candidiasis, they can look exactly the same because of the maceration effect of the sweat. It alters the initial picture of the lesion or the primary lesion. So that one you have to keep in mind. And as you are diagnosing any lesions in the flexures, you may need to first check for a biopsy, and then the biopsy can guide better on what you're dealing with at that material time. Then the next variant is what we call the oral psoriasis, or the involvement of the oral mucosa. So even the mouth can end up getting affected by psoriasis. Sometimes it can be even the only presentation of psoriasis, or it can occur in conjunction with the acrodermatitis continua of Halopo. So in this case, in the oral involvement, it usually loves the tongue, and it will give you what we call the annulus migrans, which exactly looks like the geographical tongue. So people, the geographical tongue also called the wandering rush of the tongue. So, or the benign migratory glossitis. So in that case, you'll see someone gets a little bit of erythematous denuded annular plaques that usually move from one area to another. Sometimes asymptomatic, or sometimes they are a little bit painful. So even in psoriasis, you can get the annulus migrans that you will look like the geographical tongue. We know other things like the fissured tongue, also called the scrotal tongue. So sometimes even psoriasis can have that mixed picture where you have the geographical tongue and then the tongue is as well fissured. So you have to take note in patients with geographical tongue because it can also be psoriasis. So you have to look at the tongue, examine the nails, examine the rest of the body, examine the scalp, and then try to hunt for any other features, including examination of the joint, or if they have any joint pains. So still, that's like you can see in this picture, that's what we shall see in all involvement of psoriasis. So when you go to the nails, we see that psoriasis of the nails can affect almost up to 80% of patients with psoriasis. So every time you see a patient with psoriasis, check their nails, and most of the times you will see nail changes, even if they are subtle. You have to look for them. So in a survey done in Netherlands, it reported up to even 79% of the individuals with psoriasis had nail involvement, and sometimes up to 52% were experiencing pain, and then 14% were experiencing even major daily life restrictions, meaning that the nail involvement was so hard and painful that it restricted them from doing their day-to-day activities. So when you are examining a patient with psoriasis, nail changes that you can see include the following. You can have nail pitting. In this case, you will see very, very, very tiny pits on the nails, and this is caused by parakeratotic foci in the nail matrix. Then you can also see leukonychia. In this case, the nail will look a little bit white, and then you have the current, and this is usually results from the mid-matrix involvement. Then you can also see what we call the oil drops, also called the salmon patch phenomenon. This one reflects the leukocyte exocytosis beneath the nail plate, and you can also see splinter hemorrhages at the proximal nail plate side. This is usually caused by increased capillary fragility that comes with psoriasis. You can also see subungual hyperkeratosis and then distal onycholysis. So all these features, we usually say that we have at least about 10 nail changes in psoriasis. They should be on your fingertips and you should be able to remember them so that when you're examining a patient, you can look for all these changes. So for example, in this picture, we can see this nail pits. Then we can see this longitudinal ridging with disruption of the cuticle. Then in this case, you see the nail plate, all of it is dystrophic. You see now all the nails here are involved with a sandpaper feel or change in texture. Then if you are to look closely, even you have some little splinter hemorrhages at the base of the nail. So when you see such nails in the patient, you have to make sure that you examine and then see whether if it's nail psoriasis or no. So sometimes nail psoriasis can be the only type of psoriasis the individual gets. Then they stay with it for a very long time. People treat fungal infection, the fungal infection are not resolving with itraconazole, and then they end up saying that, oh, maybe it is maybe something else. That's when they get the idea that, hey, there are other things that can call 10 to 20 nail dystrophy or 20 nail disorders like psoriasis and lichen planus. So the other involvement, which is psoriasis affecting the joints, that's what we call psoriatic arthritis. And as we had mentioned earlier, this can affect up to 30% of patients with psoriasis on the skin. And sometimes it can also be alone, where you have psoriatic arthritis without even actually having skin involvement. So that type is usually rare. So it can even be the first thing that can occur to precede the skin involvement in about 10 to 15% of the patient. And it's very hard to diagnose because there's no particular serological test that is available. So the hallmarks, usually you can see erosive changes on radiography, oftentimes seen years even before the initial peri-articular inflammation that we usually see. So when you're doing X-rays or CT scans, you see now erosive changes of the bones that and the joints that usually can signify psoriatic arthritis. So the risk factors usually will depend on the severity of psoriasis. Mild psoriasis, moderate, may not give you joint involvement, but the severe forms are usually more associated with joint involvement. So the other risk factor, if someone develops psoriasis at an early age, they end up also having it extending to the joints. So also being female is one of the risk factors for you to get nail involvement. And then sometimes there's a thought of genetic predisposition. And when you look at psoriasis of the joints, we also categorize it further into 5 types. And these 5 types are different, and it is key to know all of them because sometimes you can end up confusing it with other disorders that can affect the joints, like rheumatoid arthritis, like reactive arthritis. So all those can be confused with the psoriatic arthritis. So it's very key to make the diagnosis because once you get the diagnosis and you treat, the patient can actually get better. So these are the 5 types of joint involvement or psoriatic arthritis. The first one being what we call the mono or asymmetric oligoarthritis. This is the most common type where just one joint is affected. And in this case, you can have the inflammation of the distal interphalangeal joint or the proximal interphalangeal joint of the hand and feet. And or you can have both of them involved at the same time. And it usually gives a classic sausage-shaped digit. So usually the hand gives a sausage shape, like as you can see this one. This one looks like a sausage, right? So that is what you usually get. This is what we call sausage-shaped digit. So sometimes you can also have involvement of the metacarpal joints, and sometimes you can also have this accompanied by inflammation of even larger joints. But what is clear here is that you have mono or asymmetrical arthritis. So sometimes you're having only one side, maybe like this finger is involved, maybe this joint is involved. Then when this one is healed, another one is involved, but only on one side. That is what we call asymmetrical. That's why it is called asymmetrical. Then you can also have arthritis of the distal interphalangeal joints. So in this case, it is usually exclusively involve the distal interphalangeal joints. So in this case, it is the most classic presentation of psoriasis. involving the joints, but it is also not very common. And in this case, someone will have joints becoming a little bit fixed in position. They can't move them with limited motion and a little bit of pain. Then you can also have rheumatoid arthritis-like presentation. In this case, the involvement mimics that we see in rheumatoid arthritis that affects the joints between the metacarpals and then the carpals, like as you can see in this picture. Let me show you here. So here, so you can have psoriasis affecting these joints here. That will now be like the one we see in rheumatoid arthritis. So we also have what we call arthritis mutilans. This is the severe form and very, very uncommon, like not really easily seen. And it is rapidly progressive. It involves the joint resulting to inflammation and destruction of the joint, and it comes with permanent deformity. So this is the type of joint involvement that you would want to treat aggressively because it is also very, very aggressive. So the digits that are affected will become a little bit shorter as you are damaging the bones and the joints, and at the end of it all, they'll be shorter, wider, softer to palpation because you have lytic involvement of the bones. You are breaking down the bones, so you have now spongy bones, and we usually get what we call a telescoping phenomenon, like you can push and then like as if the liquid can enter each other, something like that. Then you can also have psoriasis involving the backbone, the vertebra, the backside, resulting into spondylitis and then sacroiliitis. So in this case, you are seeing something which will be similar to ankylosing spondylitis that we usually see as the common bone involvement in elderly patients. So you see it also manifesting as a type of psoriasis. And we've said that earlier that sometimes in some of the cases, like 10 to 15% of psoriasis, they can have psoriatic arthritis being the initial presentation. So you may find that patients being managed for ankylosing spondylitis, they're actually managing psoriatic arthritis. You get the point. So you need to be very, very careful when it comes to diseases that can present in different ways. So as you can see in this picture, if someone has rheumatoid arthritis or even gonococcal arthritis or juvenile idiopathic arthritis, it will usually involve the wrist joint first, mainly, and then osteoarthritis will involve this joint that connects to the thumb. Then rheumatoid arthritis will affect this the metacarpal in joints. And then when you come to psoriatic arthritis, it will love to affect the distal joints. Whereas sometimes this is usually a common site for reactive arthritis. Then psoriatic arthritis loves to do this the proximal interphalangeal joints. Then we can look at other disorders that are related to psoriasis. One of them is the linear verrucous epidermonephus, the inflammatory type we call IOVEN. And this time round, it can also have psoriasiform appearance, but in this time it will follow the Blaschko lines. So that will be a little bit more distinct, but it may be hard also to distinguish from linear psoriasis because sometimes even psoriasis can have a linear pattern. Then reactive arthritis, formerly called the Reiter's disease. You know that this one gives you arthritis, and then ocular and oral ulcers. It can also come with psoriasiform skin lesions. So if someone has a skin lesions looking like psoriasis, they have urethritis, then they have joint involvement, eyes and oral mucosa involvement, you may think about the reactive arthritis if they also have joint involvement. Though this is commonly seen in men and triggered by chlamydia infections together with shigellosis. So the skin lesions are only seen in 5% of patients with Reiter's disease, so it will be a little bit rare, and oftentimes they get involvement of the soles and extensor surfaces of the extensor surface of the hands and of the upper limbs and lower limbs, and this is what we usually call the keratoderma brenorrhagicum. So this is what we see in Reiter's disease, and you'll find that it looks like the acrodermatitis continua of Halope. So this disease really, you need to know actually what are the differentials in each case. When you see a particular manifestation, then you can now work around and rule out one by one to make sure that you're not making a mistake. That's why every diagnosis that you make, at least put 3 to 5 differentials, so that in case you're wrong the first time, at least your differentials can capture those other most likely conditions that can be like what you're seeing. And then we have a strong association with HLA-B27 in some patients. So we also have another one, the one we call Sneddon-Wilson disease, or what we call the subcorneal pustular dermatosis. So this is usually one of the conditions that can be confused with the generalized pustular psoriasis. But in this case, you will still see annular or polycyclic lesions with very, very superficial sterile pustules, just like we've seen in pustular psoriasis. And in this case, it can have a cyclic course where a pustule can resolve and then recur, then goes and comes back. And oftentimes, it's associated with IgA paraproteinemia. And it is very good to separate from others, because for it will respond very well to dapsone, and it requires immunofluorescence tests to differentiate it from IgA pemphigus. So as even when you take off the sample, it will look like IgA pemphigus. You know, pemphigus, the blistering condition that usually gives you the subcorneal blisters. So even the subcorneal pustular dermatosis will also give you a similar picture, and you have now to do direct immunofluorescence to make sure that you tell the difference. So in this case, this is how subcorneal pustular dermatosis will look like. We have said that sometimes it can give you some annular or polycyclic pattern. So in this case, we're having this polycyclic lesions, and then you have pustules all over. So this is how it will appear like in black skin with this erythema around, and then this is in this case generalized. So now this is how reactive arthritis will look like, and this is how the lesions of keratoderma brenorrhagicum will look like. Now you see how they're now looking like deep-seated papules and pustules and macules. They're similar to what we usually see in palmoplantar dysidosis, or even Pemphilox, or even tinea manum, or even what? Acrodermatitis continua of Halope, even the pustulosis of palms and soles that we usually see in psoriasis. So when you see all this line of differentials, you need to know that how each of them presents and what are the other associated signs. As you can see in this patient, you have the palmoplantar involvement, but then you have urethritis. So most likely they also had oral involvement, eye involvement, and that allows you to tell a difference. And that one is seen with chlamydia infections together with shigellosis. So all this is a list of differentials. Depending on your type of psoriasis, you can end up looking at particular triggers, and particular clinical manifestation makes you to think about particular differentials. So this is the list of differentials: seborrheic dermatitis, lichen simplex chronicus, contact dermatitis, squamous cell carcinoma in situ, mycosis fungoides, dermatomyositis, especially if you have scalp psoriasis, hypertrophic lichen planus can look like psoriasis, keratotic eczema, erythrodermas, gutted psoriasis, tinea corporis, and the rest. So when you look at histology, if you take off a sample to see how psoriasis looks like under the microscope, you'll get this regular acanthosis, oftentimes with elongated ureter ridges, which we call psoriasiform. And then you have alternating zones of hyper, and then in the epidermis, you have now thinning of the suprapapillary plates, And we have areas of parakeratosis in the stratum cornea with what we call monoabscesses, where you have neutrophils as being recruited and then being in a particular section. We can also have collection of neutrophils within the stratum spinosum, and that's what we call spongiform pustules of Kogochi. So in this case, if I may show you, so in this case, we can see this parakeratosis here. This is your stratum. This is your stratum corneum, and then you see this parakeratosis and then hyperkeratosis. Parakeratosis means retained nuclei within the stratum corneum, and that usually comes about because of the increased turnover of cells in psoriasis. So the maculation process usually is not complete, so you end up with retained nuclei in the stratum corneum. So because of that process that is usually very rapid, you don't have the stratum granulosum, that is the hypergranulosis, like you can see in this section here. You don't have the granular cells. They are bluish. So in this case, you don't have them there. So that is the loss of the stratum granulosum, or hypogranulosis or agranulosis. We see it in psoriasis. Then you have this blood vessels because of the angiogenesis we talked about. Then you have these blood vessels here, as you can see here, with the red blood cell inside there, even here. And you have clusters of neutrophils in the dermis, sometimes even in as high as the stratum corneum, where we call them monos abscesses. If they're in the stratum spinosum, we call them Kogochi. And then you have these red ridges that are usually very elongated, and regular. We call that regular acanthosis, and we see that in psoriasis. And then usually the red ridges at the base, they're club-shaped or rounded. They're not the sharp edges that we usually see in the normal skin. So we say that we have what we call the spongiform pustule of Kogochi. In this case, we have collection of neutrophils that is seen within the stratum spinosum, and this is what you are seeing here. This arrangement here, and most times it usually gives a clue of psoriasis. This is another picture, high magnification, giving you this. All this is acanthosis. This is a very thick epidermis. So in our previous lectures, we may notice how many layers of skin we have at each layer. If you've not watched, you can go back and watch about a lecture we did on structure of skin, so that you know that now in this case, this will be appearing as an abnormal layer. Instead of having about 10 to 5 layers, you're having over 10, over 50 layers. This is what we call acanthosis. So this is another another histology slide trying to show you the acropustules that you see in psoriasis. In case you're and usually these are sterile pustules. So how do you know that this is acro skin? Because you have this extra layer, the one we call the stratum lucidum. As my cursor is moving, that's a little bit translucent layer. Then this is the stratum corneum, and you see this. It is bluish, out of retained nuclei, and then you have this this regular acanthosis that you see here. Okay, showing you the same arrangement. Regular acanthosis and the rest. So when you go to management, psoriasis is one of the conditions that has had multiple drugs being used to treat psoriasis. And over time, people have used different medications, starting from sunlight exposure, starting from giving Holter, starting from other irritant medicines like anthraline and the rest. All these have been used from time immemorial. So depending on your patient, the surface area that is involved, the severity score, if you've done the severity score, and then the available medications that you have in your setting, you can choose from the following first line, second line, third line, depending on availability. So when you're doing investigations, usually psoriasis may not have particular specific investigations, but you after taking over biopsy and confirming, then you can go ahead and treat. Then the other investigations that we usually do are the baseline investigations. We do this because of the drugs that you're going to give. You want to have a baseline and then see how the disease process response as you're giving your treatment, as you monitor also for the side effects. Then If you think that the trigger is infection, you may need to do blood cultures for streptococcal infections to make sure that they are not the ones driving the infection, especially if a patient has gutted psoriasis. Then you may need to do calcium levels. We saw hypocalcemia being one of the things that can cause or exacerbate psoriasis. So you may need to also do levels of potassium, sodium, calcium, phosphate. Then you do assault, you do blood cultures, and then all these are aimed at knowing what is the underlying trigger. So under first line, depending on the variability, we can have drugs like anthraline. You can use Colta, salicylic acid, topical corticosteroid, vitamin D analogs like aspartame, and then serotonin, which don't usually available. Then sun exposure. You told the patient to be under the sun for significant amount of time, because we know that under the sun we have the natural UV light, and it's one of the treatment options used for psoriasis. Then other steroid-sparing drugs like dacrolimus, pacrolimus can also be used for first-line treatment. So oftentimes you may find fixed drug formulations where you have maybe steroid combined with vitamin D analog, and then like solid, you may need to give that as your treatment. But then you can also give keratolytic agents in case the plaques are very thick, like salicylic acid, even urea, can also be used to take down those plaques. So under second line, you have UVB. In this case, you give narrowband UVB, but you can also give PUVA. In this case, you're using Solarin with the UVA, and then you can have oloacitretin, apremilast. This is a biologic, adalimumab, etanercept, infliximab, and then all these other biologics. But in this case, ours readily available is methotrexate, and then sometimes you can also access cyclosporin if the funds are available. Cyclosporin is also available. So in second line, you can do, in our setting, you can do the phototherapy, and then methotrexate and cyclosporin. Then in case things are failed, you can combine therapies, both the ones you used in the first line and second line, provided there is no drug-to-drug interaction. Like phototherapy can be combined with methotrexate and the rest. And then in that case, you can add other things like 5-fluorouracil. You can add sulfasalazine. You can give even mycophenolate mofetil. You can also give the thioprine, and then you can also give colchicine, and then other newer biologics like golimumab, tofacitinib, and then the JAK kinase inhibitor given as topical treatments. So these biologicals are more effective, though not yet available in our setting, but this is where the trend is heading, and most people are already there. And I think currently tofacitinib can be accessed as well in our country. So it should be one of the drugs that you can run to in case you have recalcitrant psoriasis that is being stubborn. Then these are the drugs that we've highlighted and how they work. And the target etanercept, you know that it is a tumor necrosis factor alpha inhibitor. Infliximab, the same. Adalimumab, the same. And then secukinumab is usually interleukin 17A and then 23 inhibitor. Then you can have things like guselukimab, which is also interleukin 23 inhibitor. So all these drugs have been approved and they can be used safely in treatment of psoriasis. So the future and treatments that we are thinking about, the current drive is towards achieving stepwise treatment. In this case, we do stepwise approach, first line, second line, third line. And usually in our setting, we start with topical corticosteroid, we do phototherapy, then we go to systemic treatment, the methotrexate, cyclosporin, and the rest. Then if everything fails, we go to the biologics. Then we have emerging therapies that target biologics that usually target now the specific drivers of psoriasis, including interleukin 17, interleukin 23, and interleukin 17 receptor. So all these drugs now are very, very specific, and they go and inhibit the pathway directly without causing side effects in the rest of the body. Then we have smaller molecules that are being developed, like the JAK1 and 2 inhibitors, the protein kinase C inhibitors, P23 kinase inhibitors, and the rest. And you find that the current development is trying now to link the drug response to someone's genetics. So they take your gene and they know that you have a particular set of genes. Then they develop a drug that is very specific to your genetic makeup, and it will help you cure the disease. That's the current trend. That's where we are heading in this fight against psoriasis. And this is a more cost-effective strategies and then more effective. So instead of treating psoriasis for eternity, you give a drug, maybe a patient is given a subcutaneous injection once a month, and then that's it. And then they are better and are doing other things. Thank you very much. I know the lecture was long, but that's what we had for today for psoriasis. And I encourage you actually to share these videos with your friends and put a comment in case you want something to be changed, in case you want us to discuss a particular topic of interest. We recommend that you can let us know so that we serve you better. Thank you very much. God bless you.